My name is Stephen Howell, and I'm a professor of mechanical engineering at UC Davis, and I practice orthopedic surgery in Sacramento, California. And I'd like to share a presentation with you entitled, Is a femoral tunnel in the PL bundle or so-called anatomic location too low in ACL reconstruction? These are my conflicts of interest. I would like to share 4 objectives with you. One is provide evidence the ACL graft tension is too high in the too low PL bundle or anatomic location and more normal in the so-called ideal middle femoral tunnel location. I would then like to provide evidence that the high ACL graft tension in the too low PL bundle or anatomic location causes an unacceptably high failure rate in ACL reconstruction. The third objective is provide evidence that the ideal middle femoral tunnel location performed with the transtibial technique minimizes increase in anterior laxity because graft tension is more normal. And finally, share that we should be sensible and cautious about criticizing tunnel placement in ACL reconstruction. So let's look at our first objective, that ACL graft tension is too high in the too low PL bundle or anatomic location and more normal in the ideal middle femoral tunnel location. Let's begin by defining what we call a too low PL bundle location for the femoral tunnel. And here you can see a marker on the right knee of the lateral femoral condyle showing where the too low PL bundle location would be. There the tunnel is drilled, and here the graft is in place. And this really low position, outlined by red, defined by the fact that the tunnel is abutting the articular surface of the femur, is in our view too low, as I'll show in a moment. And it also allows a too medial placement of the tibial tunnel over the PCL. So the pink line demonstrates the lateral border of the PCL in this right knee, and the shaded pink area shows that a large portion of this graft is overlapping the PCL, which will cause high graft tension and flexion due to PCL impingement. So let's look at the evidence that the ACL graft tension is too high in extension in the too low PL bundle femoral tunnel location. And we just need to go to the work by Markoff and Dave McAllister at UCLA. They looked at the anterior, posterior, and rotatory stability of single and double bundle ACL reconstructions published in JBJS in 2009. And this is their graph, which shows on the x-axis the flexion angle from 0 to 120 degrees, and the y-axis the resultant force. And in green you can see the tension in the intact ACL. It's a little high in full extension, then drops quickly and stays low throughout the motion arc to 120 degrees of flexion. But when a double bundle reconstruction is performed in the too low PL bundle or anatomic location, you can see that depending on how it's tensioned, the graft tension is much higher than that of the intact ACL. McAllister and Keith Markoff also showed that you really don't have to be low on the side of the wall of the femoral tunnel in order to prevent the pivot shift. In their paper entitled A Comparison of the 11 o'clock versus the oblique femoral tunnel in the ACL reconstructed knee, published in a sports journal in 2010. And what they showed is that moving the femoral tunnel from the 11 o'clock position to a too low PL bundle position did not reduce the pivot shift. So if the tunnel is too low, there's a negative effect from the tension being too high in the extended position, which allows the bundle to stretch, and it doesn't reduce the pivot shift. Now let's define the so-called ideal middle location for the femoral tunnel. And here's an example again of a right knee. In this knee, about 75% of the notch is occupied by PCL. And we think that in order to put the tunnel in the ideal position, you must consider that you need to perform a wallplasty until the space between the PCL and the lateral femoral condyle is at least as wide as the graft. And here you can see a round soft tissue graft that's wider than the space available for the graft in the notch, and that a wallplasty by that vertical black line will be required. So here we've performed the wallplasty, and we can place the femoral tunnel in the middle. That's why we say ideal middle location, in the middle between the top and the bottom of the notch. And notice that this tunnel is not against the articular surface. And this is what such a graft looks like when the graft is placed in the ideal middle tunnel location. Again, 50% from the top to the bottom of the notch is where it's centered on the femoral arch, and there's usually a triangular space between the ACL graft and the PCL, indicating that the graft is not subject to impingement against the PCL during flexion. And then, of course, we want to make sure that only a small portion of the graft is overlapping the PCL where the tibial tunnel is placed. and this restores a more normal tension in the graft, similar to that of the intact ACL. And we know that the ACL graft tension is more normal in this ideal middle femoral tunnel location when it's placed with the transtibial technique, based on our paper that we published in JBJS in 2003, where Richard Simmons looked at the effect of the angle of the femoral and tibial tunnels in the coronal plane and incremental excision of the posterior cruciate ligament on the tension of an ACL graft, an in vitro study. And here you can see some projections of the femur. Again, they're right femurs, where this femoral tunnel is at the 50-50 position, placed through a transtibial technique. And you can see again the triangular space that's quite large between the PCL and the ACL graft. And there's the tension pattern, a slight rise in terminal flexion, which can be normal in many knees. And you can see that as we move this graft a little bit more vertical and the space between the ACL graft and the PCL gets smaller, that the tension still stays fairly low and normal at the 70-degree position. So it's probably, instead of 50%, maybe 40 to 60. But as we get more vertical and there's no space or negligible space between the ACL graft and PCL, the tension gets very high in flexion, and this is what limits flexion and causes a stretch out of the graft and the ultimate pivot shift from the vertical placement. It's not that the vertical placement doesn't control the pivot shift, as Markov showed us. It's that when the graft is placed in that position, it stretches, and this stretch then leads to a slack ligament that you can probe, and it's intact, but the knee pivots. And so these are the positions that we would like in the green oval, again down the sidewall, midway between the apex and the base of the notch, and that the ACL graft that's placed in this low position is that the graft tension is too high in extension in this too low PL bundle location. Now, the high ACL graft tension in the too low PL bundle or anatomic location has now been associated with an unacceptably high failure rate, which makes sense because the tension in the graft will either limit the motion of the knee or the graft will stretch to allow the motion of the knee to return. And an ACL graft in a low PL bundle anatomic location has a high failure rate. And this was shown by Chang and JBJS in 2011 when they looked at the outcomes and second look arthroscopic evaluation after double bundle ACL reconstruction with the use of a single tibial tunnel, so 2 femoral tunnels and a single tibial tunnel. And what they showed is that the too high ACL graft tension in extension in the too low PL bundle location caused a tear or poor synovial coverage in a third of the PL bundles. So here's their tunnel placement. That's what the graft looks like. That's that low PL bundle location. And here you can see the graft has ruptured. So it's really a single bundle ACL reconstruction because the PL bundles either stretch out or are poorly functioning. And what's curious is that multiple studies have shown that even when this PL bundle is non-functional, that the remaining AM bundle controls the pivot shift when the PL bundle tears. So again, consistent with Markov's work, that you don't have to be too low with that tunnel to control the pivot shift. Now, the too low PL bundle femoral tunnel has a greater risk of revision than the transtibial femoral tunnel technique. And this was recently reported at the ESCA meeting in Geneva, and it's published in KSSTA. It's a STAR paper in 2012. It's entitled Increased Risk of ACL Revision After Anterior Medial Compared to Transtibial Technique for Femoral Drill Hole Placement During ACL Reconstruction. And this is a result of the this is a result from the Danish Registry of Knee Ligament Reconstruction. So it's a large experience of the ACL reconstructions done in Denmark. And in Denmark, the introduction of the anterior medial technique, which allows a too low drilling of the femoral tunnel, increased the risk of revision to 5% from only 3% for the transtibial technique. And they recommended, because of this adverse finding, that ongoing monitoring of the results with the too low drilling of the femoral tunnel through the anterior medial approach should be continued. The too low PL bundle femoral tunnel also has a high risk of revision here in the USA, and we're indebted to Dr. Fu and his colleagues for their prospective analysis of the failure rate and predictors of failure after ACL reconstruction with allograft, published in the Sports Journal this year. And they showed that the overall graft failure rate after anatomic double and single bundle ACL reconstruction with what we call the too low PL bundle location for the femoral tunnel with allograft was 13%, which seems quite high. So I'd like to share with you our third point, that there's evidence that the ideal middle femoral location middle femoral tunnel location with a transtibial technique minimizes the increase in anterior laxity because the graft tension, as we showed earlier in Simmons' work, is more normal. And we performed a study that was done by Conrad Smith entitled Anterior Laxity, Slippage and Recovery of Function in the First Year After Tibialis ACL Reconstruction. And this was published in the Sports Journal last year. And our hypothesis was simple, and that is when we place the tunnels so that roof and PCL impingement are avoided with the transtibial technique, and we use slippage-resistant fixation, and early recovery of function does not result in a clinically important increase in anterior laxity with the tibialis allograft because the tension in the graft is close to normal. So we used RSA, radio stereophotogrammetry, where beads are placed within the knee and within the graft bundles as well as the fixation devices to measure ACL graft stretching and migration. And we based this off and acknowledged the contribution of Rashad Khan and Andrew Amos from the Imperial College in London. And they used and evaluated hamstring and BTB autograft fixed with interference screw with RSA. And they plotted, as you can see on the x-axis, time at month intervals up to 12 months or a year, and total AP laxity on the y-axis. And what they found is that their hamstring graft stretched about 8 millimeters and their BTB stretched 5. And we were interested in this because we didn't think we were seeing this much of stretching. And so we wanted to ask the question, is this increase in anterior laxity inevitable? Or can it be avoided with careful tunnel placement and the use of slippage-resistant fixation? So we embarked on a study in which we evaluated 19 subjects. These were IRB approved. We used the so-called ideal middle femoral tunnel location with a transtibial technique without PCL and roof impingement. And again, we placed that tunnel 50% from the top to the bottom of the notch. We used a fresh frozen, non-irradiated, non-chemically treated tibialis allograft. We placed tantalum markers in the graft itself, and then we used slippage-resistant fixation, and we placed tantalum markers in the washer that was applied to the tibia and the easy lock on the femur. And then we used a load application to apply the RSA test, and this is the setup. Here's a patient in the recovery room after the surgery, and the RSA was used to compute the anterior laxity and slippage at the sites of fixation. We used by convention biplanar radiographs, and we exposed these radiographs after EMG surface electrodes verified that the muscles crossing the knee were inactive, so there was no co-contraction to mask the anterior translation of the tibia on the femur. And this was our data collection. We obtained data on the day of surgery within 2 hours of the surgical procedure, and at 1, 2, 3, 4, 6, and 12 months. And this is how the load was applied. We applied a anterior tibial translation with a 150 Newton anterior force applied to the knee, which is at the level of a manual maximum test with a KT1000. And then when it was in a displaced position, we shot the radiograph and measured the translation of the tibia on the femur. We also measured clinical parameters such as extension, flexion, function, and activity level with a variety of scoring scales. These are our results with regards to anterior laxity. We'll use the same plot that Dr. Khan did and Andrew Amos. Remember that the hamstring stretched 8 and the BTB stretched 5. And with the ideal middle femoral tunnel location placed with the transtibial technique, we saw that there was essentially just a millimeter increase of laxity at a year that was not statistically different. So we were able to minimize this so-called increase in anterior laxity by proper tunnel placement to restore the tension in the graft and slippage-resistant fixation. And we achieved this by a relatively early return of function. We found that flexion extension had returned by 2 months, that the activity level as measured by the Tegner score plateaued by 3 months, and that the return of function as measured by the Leuschom score plateaued by 4 months, but it really took about 6 months before the subjective satisfaction as recorded by the IKDC score became stable. Our final and fourth point is that I think we need to be a bit sensible and cautious about criticizing tunnel placement in ACL reconstruction, because what's on the X-ray or on the CT scan does not always tell the story. And this was based off a commentary and perspective that I and Dr. Maury Hull in our lab and Dave McAllister at UCLA wrote, entitled "Be Sensible and Cautious About Criticizing Tunnel Placement in ACL Reconstruction," because of an article by Duncan Muffels from Holland that showed that whether you use computer or conventional point and shoot guides, it's very hard, at least they showed, very hard in their prospective randomized trial to get the tunnels in their intended location. And so here's an example of this. This is a patient of my own. And when I saw this patient come back at 8 years, I was concerned because I looked at this femoral tunnel. It seemed to be in the wrong location in this 30-year-old competitive tennis player. And the question arises, by looking at this radiograph, can you predict whether this ACL graft will fail? Do you have the vision of a fortune teller? And should this ACL be revised immediately in order to let the patient get back to sport, or can we wait and see how it turns out? And to my surprise, this ACL reconstruction, which I perform with the transtibial technique, is stable and fully functional at 8 years. This patient had full flexion, which generally with a vertical tunnel, you would expect with full flexion that the ACL graft would have had to stretch on the PCL to obtain the flexion back, and this would have caused stretching of the graft, some laxity, and a pivot shift. But because we performed a wallplasty, and the initial guide pin placement was where this black rectangle is, because I have a note in my chart that I moved the tunnel 3 millimeters lateral away from the PCL. And then what we did is we placed the femoral tunnel midway between the apex and the base of the notch at the ideal middle femoral tunnel location, and we happened to have a nice space between the ACL graft and PCL, and I think this occurred because we had a relatively small PCL for the cross section of the notch, which even though the tunnel was vertical, we didn't have PCL impingement. So to summarize, the take-home message is, beware of an unacceptably high failure rate that seems to be coming out from some of these studies. We're seeing it in the registries in Denmark. We're seeing it here in the United States, that this too low PL bundle or anatomic location produces too high ACL graft tension and extension, and if the placement of the tibial tunnel is medial over top of the PCL, then you can also get too high tension in flexion. May I suggest that if you would like to reduce your failure rate, do so by restoring a more normal graft tension and use the ideal middle femoral tunnel location between the apex and the base of the notch. And if you like to do AM portal, that's fine, but keep it not too low, and this can easily be achieved with transtibial technique. Finally, evaluate notches individually. Almost always consider doing a wallplasty. Here's an example where you have a narrow graft, rectangular graft that fits good, and over there it fits fine. But if you use a round graft in the tunnel to the in the notch to the left, it's more PCL dominant, and that knee is going to need a bit of a wallplasty, and maybe just a little one for the knee on the right. And if we And so finally, the other thing that you can do is radiographically sort of evaluate your femoral and tibial tunnels to see if they fit the criteria of being well positioned. And in the coronal plane, what I like to do is, again, consider that you need to widen the notch, and don't raise the roof because that indicates where the normal ACL should be, and place your tibial tunnel through the tip of the lateral spine, so that moves the tunnel away from the PCL. And if you're going to use a transtibial technique, it's important to keep that angle that the tunnel forms with respect to the medial joint line at about 60 to 65 degrees. And that, according to Simmons in our JBJS article, gets the tension in the right amount. In the sagittal plane, you need to make sure that the tibial tunnel is posterior to the intercondylar roof of the knee in full extension. And if you're going to do the transtibial technique, it's nice to keep that parallel to the roof, because when the knees flex to 90 degrees, the femoral amoral will reach the appropriate position on the femur in order to place the tunnel halfway between the apex and the base of the notch. And I keep a website with some of these surgical techniques and journal articles if that interests you, and I also have other presentations here on the ViewMedi website. And just to close, we know that this technique has allowed us to get our patients back to sport. I personally don't take care of professional teams, but a lot of my friends and colleagues follow these type of principles, and we've had patients back, or they've had patients back in the NBA at 4 to 5 months post-op and playing in the Super Bowl with this so-called technique. And I thank you very much for your attention.